Hi everyone, good evening and welcome to the last webinar of 2023 for Plant-Based Health Professionals UK. For those of you who don't know me, my name is Rahini Bajaypur and I'm a nutritionist and the communications lead at Plant-Based Health Professionals UK. I'm really excited to welcome Jodie Winkler, who's one of our members, and she's a learning disability nurse, and she's going to be discussing improving access to lifestyle medicine with people with learning disabilities. And this is such an important topic that often doesn't get enough airtime. So I'll just come back to introducing Jodie shortly, but I also want to flag that we already have our lineup in place for the start of next year, and we're going to be kicking off with this incredible talk by Alicia Thompson, who's a nutrition researcher. And this is a paper that some of you may have picked up before, but it's the topic of the talk is plant-based diets, mortality, and major chronic lifestyle diseases. And more information is on our website, and you can register for free CPD on our website to sign up for that, and also keep on top of upcoming webinars next year. I'd also like to thank ACLM and BSLM for providing this webinar with CPD and CME accreditation. You'll receive a certificate in your inbox in a few days' time. Plant-Based Health Professionals UK is a community interest group dedicated to promoting the benefits of a sustainable and healthy whole food plant-based diet for people and planet. And I'd now like to just remind everyone, if you would like to join us as a member, this is open to everyone around the world, not just health professionals. And to support our advocacy work, you can donate via pbhp.uk/donate and follow us on social media on Facebook, Instagram, and Twitter. And now I'd like to welcome Jodie Winkler. Since qualifying as a learning disability nurse in 2018, Jodie's worked across a variety of settings, and she's going to be sharing more about her experience. She's a massive advocate for lifestyle medicine, whole food plant-based nutrition, and she provides psychological therapies for children and young people with autism and learning disabilities at Children's Society. So Jodie, would you be able to turn on your screen and then kick off with the presentation? And Jodie's going to be joining us after her presentation for a live interactive Q&A. So please do pop your questions in the Q&A function at the bottom of the screen. And I also really want to thank everyone for coming. I know lots of people will do watch these webinars and catch up, but it means a lot that you turn up live to these webinars, particularly in the run up to Christmas and the holiday season. So we do really appreciate it. You can also see that my name on my screen is wrong, but I share this with the rest of the team at Plant-Based Health Professionals, so I'll make sure I change that. And if you've got any questions, then message me in the chat. Best of luck, Jodie, for your talk.
Thank you so much, Rahini. So let me just share my screen. I hope you can all see that. So good evening, everyone. Thank you for attending this webinar where we'll be exploring lifestyle medicine in relation to people with learning disabilities. But before we delve in, let me share with you a bit about me and how I've come to be here today. My name is Jodie, and I've been an ethical vegan for the past 5 years. I currently work for the Children's Society, where I provide adapted psychotherapy to children with autism and children with learning disabilities. I'm a learning disability nurse by background, which is a profession I never even really knew existed. And truth be told, I didn't really know what a learning disability was. But after 3 years of studying, placements, and witnessing firsthand the injustices people with learning disabilities experience, I've made it my mission to spread awareness about this wonderful group of individuals. And I'd be interested to know if there are any other plant-based professionals out there who work in learning disability services. Last year, I worked as a school nurse and completed a master's in specialist community public health nursing for school-aged children. So while studying public health, I started to learn more about lifestyle medicine, and I felt empowered to make some positive changes to my own lifestyle. So I swapped EastEnders for health and wellbeing podcasts, weekends down the pub for weekends walking the Southwest Coast Path. I replaced social media with CrossFit, and I switched my vegan junk food diet for a whole food plant-based one instead, which is ultimately what led me to Plant-Based Health Professionals UK. Embracing a lifestyle medicine approach has significantly enhanced every single aspect of my life. And unlike other medicines, there have been no negative side effects. To me, lifestyle medicine is not just the key to extending lifespan, but is also a crucial factor to promoting health span. And I want nothing more than to improve the life and health span of individuals that suffer unnecessary injustices and are unable to advocate for themselves, be that animals, children, or people with learning disabilities. This presentation will briefly outline what is meant by the term learning disability and discuss the health inequalities and social determinants of health experienced by this group. Then we'll explore the 6 pillars of lifestyle medicine in relation to this cohort and highlight potential barriers individuals may experience when accessing lifestyle medicine. And finally, we'll look at how to overcome or minimise these barriers. So, what is a learning disability? A learning disability is a condition characterised by limitations in cognitive functioning and adaptive behaviour skills. These limitations may vary in severity, ranging from mild to profound, and diagnosis happens before the age of 18. It may also be referred to as an intellectual or a developmental disability, and it is different from a learning difficulty, which relates to specific difficulties in certain areas of learning. And it's really important that when you make referrals to specialist services, you use the correct terminology to prevent referrals being rejected. So when I worked for a community learning disability team, we would often not accept referrals that said learning difficulty, and we would require confirmation from the referrer or from their GP that they had a formal learning disability diagnosis. This process was timely and often delayed treatment. So someone with a learning disability may struggle to process and understand complex information. They may have communication difficulties, limited reading and writing abilities, and they may struggle to understand abstract concepts. They may also have difficulties with daily living skills, personal care, medication management, cooking, finances, and time management. They may also struggle to understand social rules and boundaries, as well as avoiding potentially harmful situations. And they may also have comorbidities such as cerebral palsy, epilepsy, and autism, which can impact their day-to-day functioning. So taking all this into consideration, it may come as no surprise to you that people with learning disabilities face disparities when accessing healthcare services, leading to health inequalities. They are arguably the most disadvantaged and marginalised group in Western society. The importance of addressing and reducing these inequalities has been highlighted in the NHS long-term plan. People with learning disabilities are at increased risk of developing certain health conditions and comorbidities. Evidence suggests a younger onset and higher prevalence of multiple comorbidities when compared to the general population. Studies suggest that people with LD experience an excess mortality rate that is 2 to 4 times higher than the general population. Life expectancy for men with a learning disability is 22 years shorter, and for women is 27 years shorter. And the most recent learning from Lives and Deaths report, which reviews the deaths of people with LD, found that 42% of deaths were preventable, which is double the rate of preventable deaths seen in the general population. Clinical trials and research studies often exclude people with LD. They're a heterogeneous group with varying levels of cognition and capacity, which can have a significant impact on research validity and generalizability of findings, as well as complex ethical implications. As such, there's a lack of evidence-based interventions and treatment specific to this population. And without research to inform best practice, healthcare providers might not receive adequate training on how to effectively care for patients with learning disabilities, which can lead to inappropriate and suboptimal care. So now I want all of you to think about a patient that you've seen with a learning disability. So this can be a current patient or a patient you've seen previously in practice. And I'd like you to keep that patient in mind throughout this presentation and consider how much of what is discussed is relevant to your patient. So firstly, I would like you to consider whether you feel like you've received adequate training to support that individual and to provide them with the best evidence-based practice to address their needs. Were you able to communicate with them effectively? Communication difficulties can exacerbate health inequalities, as individuals may struggle to understand medical information, which can lead to frustration, misunderstandings, and difficulties accessing information and services. Was information provided to your patient in an accessible format? Did they have enough knowledge to be able to make an informed decision about their care? Issues around an individual's capacity and ability to consent can prevent them from receiving person-centred, appropriate and timely care. So did you assess whether that individual could understand, retain, weigh up and communicate decisions related to their care? And if they were unable to, was a best interest meeting held with all the relevant stakeholders? Does your patient experience social determinants of health? As you well know, socio-economical factors such as poverty, low income, lack of education and employment opportunities can all contribute to poorer health outcomes. So do you know if your patient received a good education? Did they go on to higher education or complete an apprenticeship? Do they have a paid job? Do they have any savings? Do they own their own home? Communication and cognitive difficulties may prevent individuals from forming and maintaining social connections, leading to feelings of loneliness and isolation. So does your patient have strong support networks that aren't family or paid carers? And there's still a considerable amount of stigma associated with learning disabilities, which can lead to discrimination and negative attitudes from society, which can limit opportunities for education, employment and social inclusion, thus perpetuating the cycle of marginalisation. So has your patient ever experienced discrimination or been stigmatised? And what impact do you think these social determinants have on your patient's overall health and well-being? And how do these health inequalities affect the accessibility of the 6 pillars of lifestyle medicine? People with learning disabilities are much more likely to face additional etiologies for obesity over and above the rest of the population, creating complex challenges for health and social care sector. Obesity was found to be twice as common in people with learning disabilities when compared to the general population, yet research shows individuals are less able to recognise this. So the SOPHIE study, which examined the nutritional intake of competitors in the Special Olympics, found that 75%, that's 3/4, 75% of the study sample were overweight or obese. However, only 1/3 of those individuals said that they were too heavy. Consequently, this cohort are more likely than their non-disabled peers to have metabolic conditions such as diabetes and cardiovascular disease, as well as gastrointestinal diseases, conditions that can be treated and reversed through a whole food, plant-based diet. Given the complexities of collecting information on this heterogeneous population, there is a dearth of robust research that examines the dietary intake of people with learning disabilities. Different sample sizes, study populations, age ranges of participants, and methodologies used in studies make it difficult to accurately quantify the diet quality of people with LD. However, common findings from research show that the diets of people with learning disabilities tend to be high in sodium, high in fat, most notably saturated fat, processed meat, refined carbohydrates, and sugar. They tend to be low in fruits, vegetables, whole grains, and dark greens. Consequently, their diets tend to be deficient in nutrients such as vitamins A, D, and E, potassium, magnesium, calcium, and low in omega-3, folate, and fibre. It's also important to note that people with more profound and severe learning disabilities are more likely to be underweight, and they may experience higher rates of undernutrition due to feeding problems, chewing and swallowing problems, and general dietary risk. Additionally, some people with autism may have a more limited and restricted diet that impacts on their nutritional intake. So sadly, to my knowledge, there is no research that examines plant-based diets amongst people with learning disabilities. I feel that this is an area of research that could be revolutionary in addressing the nutritional gaps observed in this population. A whole food, plant-based diet rich in fruits, vegetables, whole grains and legumes has been associated with numerous health benefits, including improved cardiovascular health, better weight management, and a reduced risk of chronic disease. Introducing and studying plant-based dietary interventions tailored to the specific needs of individuals with learning disabilities could not only enhance their overall nutrition and reduce their risk of developing chronic diseases, but could also potentially contribute to better cognitive functioning and overall well-being. Further research in this area could provide valuable insights into the potential benefits of plant-based nutrition for people with learning disabilities, and pave the way for more targeted dietary recommendations and interventions in the future. So I did come across a study that conducted semi-structured interviews with 8 non-meat eating adults with LD, and the study found that participants adopted a meat-free diet predominantly for animal welfare. So the participants felt that most people with learning disabilities were not made aware of the reality that animals are killed for food. And participants felt that people with learning disabilities should be provided with accessible information in order to make informed choices about whether or not to eat meat. So consider your patient again. Do you think they have the knowledge and understanding to make informed decisions about the food they eat? Low fat, low carb, keto, fasting, plant-based, navigating dietary and nutritional nuances and understanding complex dietary concepts such as nutritional guidelines can be challenging for individuals without impaired cognition. Clever advertising and marketing can make choosing truly healthy items more difficult. Visual aids such as the traffic light systems are not necessarily beneficial, as green does not always mean that the item is healthy. So I've supported individuals who thought that they were choosing healthy options as the labels were mostly green, things like crumpets, low-fat spreads, ham and Diet Coke. I've also had individuals that have bought big packets of healthier crisps with mostly green labels, not realising that that's per serving size and not for the whole bag. Socio-economical factors can play a role in limiting access to fresh fruits, vegetables and other nutritious food. So a friend of mine who has Down syndrome has to get 2 buses just to get to the supermarket in town. She's less than 5 foot tall and struggles to walk long distances, so carrying a week's worth of shopping from the shop, on the buses and into her flat is near impossible. So instead, she shops at the local co-op, which is in walkable distance, where her money doesn't stretch as far. Therefore, she's more inclined to spend £1 on buy one, get one free biscuits than £2.50 on a punnet of strawberries. Preparing healthy meals requires basic cooking skills, and some individuals may lack the ability to read a recipe, peel and chop vegetables, use a tin opener, understand measurements, tell the time, and know whether something is cooked properly. Therefore, the amount of support an individual receives is going to have an impact on their food choices. Some people may live in residential settings where their support is shared between peers. So this can mean person-centred meals aren't provided as support staff do not have the resources to prepare individual meals. And research shows that caregivers are often the biggest barrier to healthy eating. If they lack knowledge about nutrition, this can lead to less balanced diets for the people that they support. I supported a lady with a profound learning disability. So she was non-verbal, but used some Makaton signs to communicate. And her favourite sign was this, which means cake. She would request cake every day. And every day she was given cake. She would have different staff for the late shift. So sometimes she was even given 2 pieces of cake a day. And staff felt that they were providing person-centered care and providing and improving the quality of this lady's life as they saw how joyous having cake made her. However, this raises issues around capacity, duty of care, and acting in an individual's best interest, which can be a contentious issue. Alternatively, too little support can be a barrier to healthy eating. So I supported a lady with mild learning disabilities and type 1 diabetes. So I was supporting her to be able to independently manage her insulin administration. and she lived on her own with a small care package, which did not include support hours for cooking. So when I looked at her social care plan, because she was able to turn on an oven, operate a microwave, and use a toaster, she was deemed able to cook for herself. So this meant that she lived on pizza, microwavable meals, and takeaways, which, as you can imagine, was not good for her diabetes management. So think back to your patient again. How much support does your patient receive? And how much say do they get over the food that they eat? Communication difficulties can make it difficult for people to share their dietary preferences. So I supported a non-verbal lad whose care plan stated he did not like a range of vegetables, including broccoli. And one day we were having lunch together and I caught him looking at my lunch and I offered him some of my roasted broccoli and he absolutely loved it. He had very high sensory needs, and it turns out a lot of the food people thought he didn't like broccoli, carrots, and cauliflower, was because of the way it was cooked, boiled to mush. He liked crunchy foods. So by roasting vegetables and adding seasonings, we were able to broaden his diet immensely. There may also be barriers beyond an individual's or their carer's control. They may have genetic conditions, like Prader-Willi or Down syndrome, that can increase their risk of obesity. And they may also be taking medications, such as those associated with certain psychiatric or neurological conditions commonly diagnosed in individuals with learning disabilities that contribute to weight gain. So, how do we improve the diets of people with learning disabilities and overcome these barriers discussed? I'm assuming, as plant-based health professionals, you would all advocate a plant-based diet. And there are some simple strategies, which I'm sure you already use with your other patients, such as buying brown wholemeal food instead of white processed food, choosing plant-based meats rather than animal meats. And this simple swap also takes away safety concerns around handling raw meat. Swapping unhealthy snacks for nutritious, minimally processed alternatives like dried fruit or croutons. One study I looked at found, on average, over a third of the calories people with learning disability consumed came from snacking, which may be due to the fact that individuals didn't have much say over the meals that they ate at meal times. However, they did have autonomy over the snacks that they had in between meals, and these snacks are often more accessible. If transportation is a problem, then encourage your patients to shop online if possible. And if they have limited cooking skills, then advise them to buy pre-prepped frozen foods, such as vegetables and fruits, and pre-cooked tinned legumes and spice mixes. Information should be given in an accessible format for that individual. And they may not remember everything that you've advised, so perhaps get them to record you talking, or offer to text them or send them an easy read letter with the information discussed. You may also need to make a referral to a dietitian who can support with meal planning, or to an occupational therapist who can provide adapted cooking equipment and teach them new skills. Liaise with your community learning disability team to see what support they can provide, and even request a social care review if you feel that they need more support hours. Liaise with their GP to arrange their annual health check, during which they can develop a health action plan and have a medication review. But most importantly, educate individuals and their carers. Explain to them the benefits of eating this way. Provide them with accessible information about a plant-based diet, be this easy read leaflets or YouTube videos. And encourage caregivers to lead by example and be role models for the people they support. Think about your patient. Which of these interventions could you recommend to them or their caregiver, and how would you inform them in an accessible way? How much physical activity does your patient do? So people with learning disabilities are more likely to live sedentary lifestyles and face multiple barriers when accessing physical activity linked to their disability and accessibility issues. Gyms are not only expensive and noisy, but they can be extremely intimidating, especially if you are at greater risk of being stigmatized. So do you think your patient would be able to access a gym or leisure group? Do they have a friend they could take with them for moral support or enough support hours to be able to attend? Do they have the communication skills to be able to understand and participate in activities? And concerns around an individual's safety can also be a barrier to get active. So once a week, I would support a lady to an inclusive ice skating group. However, she had mobility issues and epilepsy. So her risk assessment stated that she had to use a wheelchair on the ice, which I would have to push around. Now, this was the same lady who loved to eat cake. So as you can imagine, it was a real workout for me while she just sat back and enjoyed the ride on the ice. So let's consider everything we've discussed so far. The health and social disparities, the increased risk of chronic illness, the sedentary lifestyles, the communication challenges, and reduced cognition. What impact do you think these factors are going to have on an individual's mental well-being? A UK population-based study found that 40% of adults and 36% of children with learning disabilities experience mental ill health. Research shows half of the learning disability population are prescribed at least one psychotropic, and according to Public Health England, up to 35,000 people with learning disabilities are taking psychotropic medicines that they do not have the health condition the medicines are actually for. I supported a gentleman once with a moderate learning disability who began presenting with challenging behaviour. Now, he was put on risperidone and diazepam to manage this. And it later transpired that he had a very painful ingrowing toenail. But due to his communication difficulties, he was unable to communicate this verbally. Therefore, he communicated it through his behaviour by being challenging. And once he'd received treatment for his underlying physical health issue, his challenging behaviour returned to normal. So diagnostic overshadowing can be a major barrier to positive health outcomes, as individuals may not receive appropriate treatment for their mental health because symptoms may be disguised by their learning disability, especially if they have communication challenges. Difficulties communicating not only impacts assessment of mental health, but it also affects treatment, as individuals may struggle to access NICE recommended interventions such as psychotherapies. So how is your patient's mental well-being? Would they be able to tell you verbally, or would they need to use their behaviour instead? Would they be able to access talking therapies? And how might this impact on their sleep? So people with learning disabilities are at higher risk of developing sleep disorders such as insomnia and restless leg syndrome. Coexisting health conditions such as epilepsy, sleep apnea, gastroreflux, or pain conditions can affect sleep. Some medications and feeds may need to be administered at specific times, which can disrupt sleep patterns. Bedtimes may be dictated by support hours or carers' availability. Personal care may be required during the night. And there may also be environmental factors that can prevent sleep. So some of the worst night's sleep that I've ever had was when I would do sleep-ins in a supported living property. Doors slamming all night, epilepsy alarms ringing, and constant green illumination from the fire exit sign. So does your patient live with family, or are they in supported living, and may they experience some of these environmental issues? Do they live with others? Do they live with a partner? Research shows that only 3% of people with a learning disability live with a partner, compared to 70% of the general population. I want you to think about where you met your partner or your best friends: at university, whilst travelling, at work, a five-a-side football, mother and baby groups, through friends of friends. People with learning disabilities are less likely to work and have limited opportunities to engage in social activities, which mean that they have fewer opportunities to meet new people. Communication difficulties and reduced social skills may prevent individuals from forming healthy relationships, and these factors may put them at greater risk of having unhealthy relationships. They may struggle to understand the importance of boundaries and consent, putting themselves and potentially others at increased risk of abuse. Now, I've purposely saved this pillar until last because it seems to be the only pillar in which the general population are more affected than people with learning disabilities. However, people with learning disabilities may be more vulnerable to substance misuse due to the factors previously discussed, such as poor mental health and socio-economical issues. However, the research in this area is sparse and data varies depending on study and substance in question. Nonetheless, alcohol, tobacco, and marijuana have found to be the most used substances, but this tends to be amongst people who have a mild learning disability. So, what can you do to make lifestyle medicine more accessible to your patients and improve health outcomes for this disadvantaged group? First, I would start by assessing and improving accessibility to your service. So, do you offer longer appointment times to patients with a learning disability? Are they provided with accessible information about their visit? And do they need to be seen at a specific time of day or in a downstairs room? Are they coming alone, or would they benefit from having an advocate? And do they have a hospital passport that details their important health information? Are they due an annual health check? Everyone aged 14 and over on the Learning Disability Register is entitled to an annual health check. GP practices receive £140 per LD annual health check. That's how important they are. And these health checks are the perfect opportunity to assess patients' needs, improve their health literacy, and facilitate better health outcomes. Working with caregivers is a key to reducing health inequalities. It is vital that caregivers understand the importance of lifestyle medicine, as it is their job to support individuals with their lifestyles. Interventions should be person-centered and effectively communicated to the person. So social stories, videos, or role play can promote understanding, and liaise with your local learning disability teams who will be able to help with this. You may also need to contact social care if they require additional support to be able to access treatment. Would your patient benefit from social prescribing? What local inclusive opportunities are there for patients to meet new people, get more active, and learn more skills? Who's going to follow up with them after the annual health check? Do they have a named GP? Having a named GP may reduce the risk of diagnostic overshadowing and encourage behaviour change. Staff training should also be a priority. So I presented at this year's British Society of Lifestyle Medicine's annual conference, and I asked the audience to raise their hands if they'd ever had a patient with a learning disability. So everyone in the audience put their hand up, and I asked them to keep their hand up if they had received adequate training to support that patient. And not one person left their hand up. So speak to your learning disability teams and ask them to provide training to your staff. And I'd advise appointing an LD champion from your service who can link in with the learning disability teams and be your go-to for LD advice. And above all else, as I'm sure you already do, give your patients with learning disabilities the time, compassion, and care that they require. So the current body of research concerning the accessibility of lifestyle medicine and plant-based diets for individuals with learning disabilities is notably deficient. There's a significant gap in knowledge regarding the specific barriers and facilitators that influence people's ability to engage with and benefit from such interventions. And consequently, there is an urgent need for comprehensive research in this area. So if anyone would be interested in doing some research in this area, then please do reach out. I would love to be involved. So to summarise, people with learning disabilities are more in need of healthcare services, yet less able to access them. They are more likely to die younger from preventable causes, yet experience multiple barriers to accessing lifestyle medicine interventions that could improve health outcomes. And despite all this, there's still a considerable amount of research that addresses these issues. Here are some useful websites that have information and resources you may find beneficial, and my references are also in the end slides as well. So I just want to say thank you all so much for listening, and I hope I can count on you all to wave the learning disability flag in your professional and personal lives. Just to note, this is not the official learning disability flag. Points for anyone out there who knows which country this flag does represent. So this photo was taken on a Go Beyond holiday in Morocco. So Go Beyond Holidays offers supported holidays to people with learning disabilities and autism, and provide individuals with opportunities to make new friends, witness different cultures, and have once-in-a-lifetime experiences, like we had camping out under the stars in the Sahara Desert. So if you're thinking about social prescribing, then I would definitely recommend checking them out. And here are my contact details if there's any support or additional information you need. I would also be extremely grateful if you could please complete a brief feedback form for me, please, via Menti. It's so difficult to engage your reactions on this webinar format, so your feedback is crucial in order for me to be able to achieve my advocacy mission for people with learning disabilities. So yeah, if you could just take the time, I think there's like 3 slides of questions just to complete. You can either scan the QR code or go to menti.com and put in that code. I'd be extremely grateful. And here are my references. Okay. Stop sharing.
Great. Jodie, you did such an amazing job. That was honestly, I think it's probably the webinar that I learned like the most from this year. It's a topic that I'm embarrassed to say I did not know enough about, and I'm sure lots of health professionals listening would feel the same, that this just doesn't get taught enough, either to nutritionists or dietitians or nurses or doctors. So I'm so pleased that you covered it in so much detail, and also just so many amazing examples, like about the patient with broccoli that was really enticed by your lunch, and that's just simple things like that we wouldn't, that maybe like someone wouldn't think of, but actually just assuming that the person isn't going to like broccoli or isn't going to like something without actually presenting it in a new way. And that's kind of what your message is, isn't it? It's about presenting this information in ways that actually are accessible. So I would love to just talk a little bit about the intersectionality of other marginalized identities and learning disabilities. In your experience, do you see more challenges if someone has additional layers of marginalization on top? So, for example, if with learning disabilities, are there more negative or adverse outcomes if someone is Black, Asian, or basically a person of color, or someone who is lesbian, gay, bi, trans? Like, does that affect outcomes when it comes to learning disabilities, or affect the person's experience? Are there any studies or data about that, or is there anything that you've noticed in your own clinical experience?
So I think, as with most things learning disabilities, the research out there is sparse as it is. And actually, the research with regards to ethnic minorities tends to be even sparser, because a lot of the research they don't tend to have a lot of people from ethnically diverse backgrounds. So the LEADER report, which is in my references, they looked at the deaths, reviewed the deaths of people with learning disabilities, and actually 94% of those deaths were people of a white ethnicity. But what they could tell from the very small sample size from more ethnically diverse backgrounds was actually, as similar to the general population, those individuals were more likely to die younger. So there is still, within the marginalized group, there is more marginalization that does have an impact on health outcomes.
That's really interesting. And you also mentioned that, if someone has a learning disability, they're more likely to suffer with other chronic conditions, whether it's obesity or diabetes, and kind of multiple health conditions. Is there much research on that area as well, kind of how that having kind of additional diseases or conditions affects the person and their quality of life?
Yeah, absolutely, because they may not be able to communicate symptoms. If we're thinking about diabetes, people may have the knowledge or even be able to recognize in themselves that, oh, I'm feeling a bit low of energy. Okay, maybe I need to have maybe my sugar levels are low. And they may be able to have the ability to check their sugar levels, whereas someone with a learning disability might be reliant on other people to be able to do that. And if they're unable to be able to verbally communicate that they're not feeling great, relies heavily on the caregiver to be really in tune to that individual and to be able to pick up on factors, or if they're presenting different from normal. And what we really like to do within learning disabilities services is find out where someone's baseline is, because the baseline of someone with a learning disability may vary significantly from the general population due to their physical health or conditions that they have. And actually, what might be normal for someone with a learning their baseline for someone with a learning disability may actually be quite abnormal for the general population. So I think that's really important, and that's why including carers is so important, because they hopefully know the individual better than anyone. And especially if you're seeing someone in outpatients or in a GP appointment, and you've only got a really short time to spend with that individual, you're unable to be able to do that thorough assessment that might be needed. And that's why I would always advocate having extended appointment times if possible for patients with a learning disability.
Such a good point. Some of the lovely comments, awesome presentation, so informative. Thank you, Jodie. Eye-opening and mind-opening, such a great and informative presentation. As Rahimi said, you talked about so many issues that many of us who do not specialise in learning disabilities do not normally think of. Thank you for such a great presentation. And yeah, thanks for posting the code again. I think this is the kind of presentation that we definitely want to do more of, because this is the area that clearly so many people do meet people in their clinical practice who have learning disabilities, but there's many different areas that we wouldn't think about. I'd love to know a little bit about your story, Jodie, and how you got into kind of this way of eating and lifestyle medicine. If you could tell us a bit about yourself and your experience kind of getting to this place.
Yeah, absolutely. So it was because of my partner that I became vegan. And I think initially I was very I was doing it more predominantly for health reasons, and for me it was like I wanted to have a diet that I could stick to, and I knew that by limiting my options I was more likely to stick to a diet. But then the more I looked into it, the more research I did on it, and the more I found out about the ethical side of plant-based eating, that's when I replaced my plant-based title for a vegan title, and I was proud to kind of wave that vegan flag. And I've always kind of felt that it benefited my health massively, and I would always find it frustrating when I would support individuals with a learning disability and they would just not have the knowledge or the skills to be able to, or the resources to be able to cook and prepare some of the healthy meals that I was able to do. So I came into lifestyle medicine, as I said, when I was did my public health nursing. I started listening to podcasts and watching YouTube videos, and just really, the more I looked into it and the more I just felt the benefits when I applied it to my own life. And I kind of just felt like these are issues that everyone would benefit from, but specifically people with learning disabilities would benefit from, because as you've seen and I've presented, those 6 pillars, other than the substance misuse, actually people with learning disabilities tend to have poorer outcomes than the general population. But yes, lifestyle medicine, as I said, is something that has truly changed my life, and I am constantly listening to podcasts still and trying to broaden my knowledge as much as possible so that I'm able to kind of spread the message to those around me.
Yeah, well, you've definitely chosen a topic that I have not really seen covered elsewhere. So I think that super, super important, especially when we talk about diversity and inclusion and inclusivity and equality. This topic, you know, people with learning disabilities often don't get included from things that I've seen. So yeah, that's super interesting. What is the feedback from your colleagues and people that you work with when you bring in the role of healthy eating and diet? You mentioned that there sometimes can be, you had the example of the lady who really loved cake, and sometimes there's that we don't have that continuity of care, different people coming in, and sometimes the pushback that, oh, this is actually patient-centered. How do you approach it with people that you work with, and what's the response been?
Yeah, it can be really difficult. And I think capacity, like I said, is one of those kind of contentious issues, because if you look at that example, that cake really did improve that lady's quality of life in terms of her mental well-being, and that was something that she enjoyed. But actually, her, in terms of her physical health, the impact that that has on her life. So it's about weighing up what's in that individual's best interest, and that can be challenging, especially if you work with other people that don't have the knowledge, and you don't want to come across as being kind of preachy or anything like that. So it's very difficult to be able to, I don't know, have those conversations. And I find sometimes that when you mention diet, and especially plant-based diet, sometimes people can become quite defensive, or can take things as a personal attack. And when you're trying to work within a support group, so sometimes an individual may have, 10 plus individuals that support them on a weekly basis, and having that continuity and everyone kind of being on the same page can be really challenging. I think the important thing to do is yeah, like you said, person-centered. So chat to that individual. What is it that they want? And actually try and use some of those motivational interviewing skills with those individuals. So try and find out actually what their goals are, and from there you can then work backwards. Okay, well, how are you going to achieve that? What kind of things do you think that you can put in place to achieve those goals, be it to be able to walk to the shops and back, or to be able to go to the local social group, or whatever it is, and make sure that that is then documented and put in an individual's care plan, and that's then disseminated with the wider care group, so that they're all aware that that is the care plan. And it should be reviewed regularly. So as in my example, the broccoli example, it may have just happened that on that one specific day, someone tried to give him some broccoli and he didn't like it. And that was it then. It was set in stone and it wasn't reviewed. So I think it's really important to make sure that these things are constantly reviewed. And I just think provide information. I'm always sending friends, families, colleagues, podcasts and things to look at or to read. And knowledge is power. So yeah, I just think, and I also think as well, what a really, really important thing for people that work with or have family members with learning disabilities is to be a role model, is to lead by example. Another time I was providing health education to a lady, and I was kind of assessing her capacity on whether or not she understood the implications her unhealthy diet was having on her lifestyle. And I was delivering this, it was during COVID, so I was delivering it over Zoom or whatever. And as I was talking to this lady about healthy eating, her carer was sat opposite her, eating a big bag of crisps in front of her. So yeah, things like that can be quite frustrating. But I think in terms of that, it's like I said, educating all those involved in that individual's care, not just the individual, especially if they've not got the capacity or they are reliant on others to be able to do their meal planning or their shopping or things. You need to get everyone on board, really.
No, I love that kind of collaborative approach. I can see that there's so many different challenges, especially when there are so many people involved in someone's care, and there's, again, yeah, not that continuity. And obviously, as you mentioned, things are really expensive. The lady who went to the co-op because the larger supermarket, which had things at a more affordable price, was a bus ride away, and she would have to carry everything back. So that is a real, that's a real mountain to kind of surmount and just deal with. In terms of cooking skills, are there organizations or resources that you know of that can help people with learning disabilities to improve cooking skills, in terms of just the activities that they doing together, whether it's making a dish together or doing things? I'm thinking of things like Made in Hackney, the eco community cookery school that Plant-Based Health Professionals UK has as a partner. Are there any organisations that are trying to encourage that type of activity with people with learning disabilities as a sort of social activity with food? So
it really depends on your area, or as most things, postcode lottery, and a lot of these organisations tend to be charity based things. So and sometimes pilot schemes, so they sometimes run for a little while, so you just get into a really good one and then they stop. On MenCap, if you go onto the MenCap website, mencap.org.uk/a-healthier-me, I'll put it in the chat, and they've got like a good pack that you can download that's got information you can give to people with learning disabilities. Unfortunately, a lot of these do include a lot of meat and dairy, which I find frustrating. I know that there was a team, I think it was in Bristol, is this the website? And they would do kind of social classes where people could come learn new skills. I mean, that is something that I would love to do. That's the dream, Rahini, in the future, to have my own respite centre where individuals can come with learning disabilities and they can learn we can grow veggies and they can learn all about plant-based diets, and we can do a bit of CrossFit, and we can really put all those lifestyle medicines factors into practice. But I would advise just liaising with your local community learning disability teams to see if they're aware, because depending on service, they may be able to provide some support with that. I think it does just depend on what's in your area. OTs, so you can get specialist OTs within learning disability teams that can specialise in things like the cooking skills and that sort of thing. But yeah, I'm not aware of any specific things. But what was the one that you said, Rahini, that plant-based?
Yeah, it's called Made in Hackney. It's one of our partners. I volunteered there as well. And we have some lovely comments. There's someone who said that 8 years ago, they were able to set up a lifestyle medicine-based project that was a charity and embedded in the local community, and they're genuinely fully inclusive with people with learning disabilities, and he would like to have a conversation. So hopefully this is the start of some more conversations. And to the person, I think his name is Graham, please do get in touch with Jodie as well. You can email me or reply to any of the webinar emails, and we'll pass on her details if you're happy to. And Jodie, would you be able to share the Menti QR code again?
So I'll put it in the group.
Thank you so much. A very needed topic, and it's heartbreaking to hear some of the challenges and barriers. This has to be changed. We must all engage in helping everyone to access lifestyle medicine and achieve their potential. I couldn't agree with this comment more. I think there was an article several years ago about lifestyle medicine, is it, elitist as a movement? And I suppose the term lifestyle does kind of give that connotation, this idea it's only for the 1%, and it's definitely baked into certain lifestyle medicine spaces as well. And I think the true message of lifestyle medicine is to be inclusive, to meet the person where they're at, to bring in all of those different aspects. And so I think I totally agree. It's everyone should be able to access lifestyle medicine. It should not just be for a few, which is sometimes how it is billed, or sometimes things that you see online as well. And I did want to ask about social media, Jodie, and the impact of that on people with learning disabilities. Obviously, there's been more awareness raised from social media just in general of neurodivergence, and particularly of people with learning disabilities, but and people having their own TikTok page, and I've seen that. What are your thoughts on that? And is it a double-edged sword, or can social media be a positive tool in this space for kind of for community and other?
Yeah, I think in terms of community and spreading awareness, definitely. I do think it can be quite risky for individuals, especially if they we get it all the time, don't we? The spam accounts that contact you, or people that try and scam you out of money, or that sort of thing. So I think it like you said, Rahini, it's a double-edged sword. It can be really good for connecting people, and a lot of my friends with learning disabilities are on Facebook, and you can always count on them for a like for any post you put on. So it's great to connect with them on social media, but they are at increased risk of potential catfishing or scams or vulnerability, that sort of thing as well.
And I think devices can be quite addictive, but all of us, and then they can be yeah, it can be difficult to kind of monitor someone's safety online as well. So I suppose there's lots of different aspects, but I was also thinking of things like Facebook groups and groups for people, and just seeing more people that look and sound like you and access information in a similar way, and how that could be, because sometimes, as you mentioned, there's far less opportunities for just generally meeting someone with a learning disability in many of the spaces that you said most people might meet friends, romantic partners, you know, whether it's the workplace or parties, or even just going to the library or something. Like, it's just so many different, there's so many fewer opportunities. So I think that it's really key. And going forward, if there's one thing you'd like everyone who's listening today to take away from the session, what would it be, or what is your message that you'd like to end on?
I'm concerned that my presentation is quite negative, and it highlights lots of kind of barriers and accessibility issues. And although I do want people to go back and, like I said, wave that learning disability flag and spread awareness in their group, I want them to also realise, like, just how fantastic people with learning disabilities are. I don't want to kind of generalise, but all the people that I've ever supported, or any friends that I've got with learning disabilities, they just bring so much joy to my life and the lives of individuals around them. So I just think that be kind, be aware, and yeah, just wave that learning disability flag in your services.
I think that's a beautiful message. I think that, as you said, I think you showed, I don't think your presentation was negative at all, by the way. I think it showed the full humanity of people with learning disabilities, and how much more we need to do as a society to look after people and to support them where they need it, and to support people within the system, and to make lifestyle medicine accessible. So I didn't think it was negative at all. And I think all the examples that you showed just showed how much even just small changes can benefit someone who does have a learning disability. Small tweaks, small lifestyle changes. It does not need to be all or nothing. And I think that approach just especially doesn't work in this area. So I felt that it was actually very inspiring for people to listen, to make that assessment of their patient and meet them where they're at, and give them some tools, and don't just assume, but actually listen to them and try things. And the broccoli incident and so many other things where you showed that it's just keeping that open mind and not just assuming you know something about someone or what they're going to like, and yeah, treating them with that compassion and kindness. So lovely note to end the webinar season on. I just want to thank everyone for supporting and all the lovely comments. And Jodie, everyone,
thank you guys
so much. They found it so helpful, and they found it really enlightening and new information that people haven't learned before. So I'm going to share this far and wide. Our slides Jodie's slides will be sent to everyone here today, and usually we just have recordings for members only, but we'll probably, you know, if you want to get the recording of this or share it with anyone, then just reach out to us and we'll share the link with you. Thank you so much, everyone, and good night. Thank you, Jodie.
Thank you, Rahini. Thanks, everyone.